Thank you, Essie, and absolutely fantastic to see those videos. So hopefully everybody will have got a lot out of that. So we're going to spend the next 20 minutes or so just having a discussion amongst the panel who've all been involved in the creation of these videos. Maybe just to start off with, can we have a bit of a chat about why were these resources developed? And I wonder, actually, maybe start with you, Lindsay, given that you were the doctor and the star of the videos, and do you want to say a bit from your own perspective?
Yeah, thanks. Sorry, I definitely was not the star, but thanks for that. Yeah, I think from my perspective, certainly as like a day-to-day clinician in sexual health clinics, it's really important to me that like our services feel accessible and inclusive, and I think traditionally probably haven't been like that. So it was really nice to be able to be involved in a project where I could just show this is what happens, this is what you can expect. Like, we're not targeting anyone with these questions, everybody gets asked these things. We try and be inclusive, comprehensive for everybody, and I hope that the videos reflect that so people can just feel a bit more reassured, takes away some of the fear of the unknown and unfamiliar for people.
Thanks, Lindsay. And Claudia, I mean, you've obviously been involved at a kind of national level at looking at how we widen access to PrEP. And do you want to say a bit about it from that kind of context?
Yeah, absolutely. And also from some of the research that we've done, particularly with women of colour in both Glasgow and in London as well. And I can see that Ingrid and others involved with that study are on the webinar, which is fantastic. I think we identified very quickly that as much as we as clinicians hope that we are trained to be non-judgmental, to be open, and really encourage people to have very frank discussions with us in sexual health settings, these may well not be comfortable settings for all people, and particularly women of colour were telling us that for a whole variety of reasons they were not. I think for us within sexual health, it runs very deep, that we do want to do our best for people and that we really aren't judgmental, or we try not to be. So for us not to have and to realise that we needed help to get the language and the way in which we use words with people of particular ethnic backgrounds to enable those conversations to happen was absolutely critical. And I think even more pivotal than that, in our discussions about widening access to PrEP, and also thinking about all who could benefit as opposed to people at, heaven forbid, high risk, we needed that language. And we also felt that unless we started making these early steps in that direction to upskill clinicians, those conversations would never happen. That means that people who could benefit from PrEP would not be offered an HIV test and couldn't benefit from PrEP because they wouldn't know about it.
Thanks, Claudia. So clearly not just about raising awareness and changing guidelines, it's about doing something about the barriers that people face when they see clinicians as well.
It is. This is about the one-to-one as well as the wider barriers about whether sexual health services are the settings in which people want to access PrEP.
Great, thank you. And Jen, just thinking about some of the work you've been involved in around PrEP and evaluating it, has it chimed, have these videos and where we've got to kind of chimed with what you learned in that research?
Yeah, I mean, this was my first time seeing the videos alongside everyone else, so it's fantastic to see them. They're absolutely brilliant. Yeah, I think the kind of language that's being used was something that really strongly came out of the PrEP evaluation, and ensuring that people, don't feel stigmatized or targeted or judged when they're coming to consultations. So I think these videos really nicely address that.
And just to add on that, so when we talk about culturally sensitive ways to have conversations, a lot of the time it can always be seen as the sort of insulting way, or the or insensitive way rather. And, sometimes it's less about that, and it's about, how can we understand the dynamic of the conversation or the relationship, and then, take advantage of that opportunity to give the best possible information, but also receive, sort of provide the best possible outcome for both sides of, people having that conversation. So I guess sometimes it can be less about not creating offense and more about sort of understanding the dynamic of conversations.
Yeah, I mean, I was just going to come to you, Essie, and ask you about that in terms of, your professional perspective, and why did you want to have these resources developed? Was it really about that kind of clinician-patient dynamic?
Yeah, I get one of the recurring questions that people ask, when people of ethnic minority background is, I don't know what to expect when I go into the clinic. I don't understand what I'm going to be facing. So maybe I would try to avoid it as much as I can. And that could be for, a myriad of reasons. And so it's about just, for on the side of the clinicians, helping to navigate how to, like I said, how to navigate the relationship and the conversation, but also demonstrating to community members what a consultation could look like. So you might not be able to physically walk in on a day-to-day basis and just shadow, but these videos will hopefully be able to provide that sort of perspective of, oh, this is what to expect. I'm less worried, but also prepare myself to be able to ask my clinician questions that pertain to my health. Yeah.
Thanks, Essie. I think the videos definitely kind of demystify what an appointment at a sexual health clinic is like, and what kind of conversation you should expect. Chioke, from your perspective, why did you want to see these resources developed? Maybe you can hear me.
Sorry, can you repeat your question?
Yeah, I was just asking, why did you want to see these resources developed? What was important to you about having these videos created?
Okay. I come from a community, I come from a place where issues around sex are mostly seen as taboo. Like, people don't want to talk about it, even though people are having sex. People don't feel free to talk about HIV, AIDS, and drugs and stuff. So it's because I did a little of peer education in Nigeria for men who have sex with men. And it is a topic where people don't want to get involved in. Yeah, so it is very hard. And then coming from a very homophobic country, you find out that most people, if this is a healthcare that many people need, but then they can't easily have access to it. Yeah, so it was important to me that, like, when Esther told me about, oh, this is what we are planning to do, I felt like this is personal to me. Yeah, it is. I felt it's something that my community really need. Yeah, so that's why it's so important to me. Yeah.
Great, thank you for that. Yeah, so really important to be able to kind of show the community that we can have kind of very empowering, safe, much easier conversations about sexual health.
Yeah.
Great, thank you. And just moving on to now, we've got these resources. How are we going to use them? And maybe start with you, Essie, with this one.
One of the ways we're using them is, in this webinar just right now, being able to get the resources to people who would benefit from the learning that we've sort of gotten out of it, not just the making of the videos, but everything that sort of went into building up to this process. We'll be talking a little bit more about that as the conversation goes on. But I think getting an awareness of, and one of the things that happened, when I was discussing with community members, is we want the information. So it's we just need to be able to help whoever is providing it to provide it to us in the best possible way. So that's kind of open to use this to educate, healthcare professionals, clinicians in training, and anyone even just out of, healthcare settings, but who is interested in having conversations about PrEP and HIV with the people they work with.
Thanks, Essie. And Claudia, just from your perspective, how do you see these videos being?
We want to use these in all of our services. I think Lindsay made it look too easy. She was beautifully slick. She didn't bat an eyelid, but I think it's maybe interesting to know how we got to those forms of words, because throughout our training in medicine, we develop our own patter, what would have been called bedside manner. And we develop that, and I hope constantly refine that over the years, and also modulate that according to the person in front of us. And the process of iterating and coming up with a form of words that were really carefully crafted, we put our ideas down as to how we would normally script these, And we received really fabulous feedback from our co-production team. And we began a process of understanding why it was important that certain key phrases were phrased in that particular way. And I think you'll find as another web resource, there's a lovely interview between Essay and Lindsay where they talk about particular key phrases that were absolutely refined by co-production, that we were very certain we needed to ask those questions, but we didn't know the best way to ask them. And the way that we asked them first was not the best way in terms of our co-producers. So it was almost like a dance that we did collectively of refinement, so that some of those phrases that sounded so fluent, so easy, were actually very carefully scripted together. And I've learned from this, and this will, I know, help me in my conversations, and I hope help others. And the format that these films are in, anybody can watch them. And we want them, we hope that them being made available will be really useful. I had a really interesting conversation with a colleague yesterday who pointed out that there are some other ones too that we can all learn from, done by Positive East, an NGO in East London. And I think there's a place for huge numbers of these films because every consultation is subtly different. And these two, the actual reasons for coming for these sexual health presentations were largely provided by the community co-producers, and there is obviously scope for many more consultations to be done in this way with slightly different nuances, and this is really all about nuance, so I look forward to many more.
Thanks, Claudia. I was just wondering as well how the videos might be used differently with specialists, clinicians, and more generalist healthcare practitioners or GPs, and I guess we want to try and reach a wide workforce.
I agree, and certainly as part of our strategy in the HIV transmission elimination strategy, these films can be signposted as resources very widely, and we hope that NES National Education Scotland will also be able to highlight them for us, and certainly Public Health Scotland have offered to tweet about them, which will be extremely beneficial in making people aware of these films. Medically, within our clinics, it's relatively easy to publicise these, and certainly using our links with community services, we hope that they will be available in a way that is slick and quick for people to assimilate the important phraseology and the important, I think what Essay mentioned, cultural understanding of the way the conversations are going. So in those respects, we hope they can be of very diverse use, even if someone is just signposting about PrEP, signposting about PEP or HIV testing.
Thanks, Claudia. I suppose just kind of moving on to the process. So I think what's been great about these videos is that the community were involved in the actual development of the resource, of the script, etc. Essie, do you want to talk the audience through how we did it?
Yeah, so we, like Claudia said, there was a lot of back and forth conversations between community groups who were taking part in sort of defining how these video resources were going to be made and how they would look like. And, you know, clinicians as well, Claudia and Lindsay being sort of the two persons who were really invested in the entire process. So the first thing was, you know, reaching out to some of the people we work with in Waverley Care who have at one point or the other expressed interest in being involved. So and then looking at, okay, what's the process in achieving this, you know, what is actually achievable and where can we go? So it started off from just the PrEP video, and, you know, the community members I spoke to first were like, why not let's talk about testing as well, but also why not let's talk about, you know, another aspect of like living with HIV, which is another video that's kind of underway at the moment. And then from there, we had like an extensive, you know, consultation with Claudia and Lindsay, and a recorded role play of Claudia and Lindsay being doctor and clinician, or clinician and community member rather. And then taking that video to a workshop with some of the community members. Chijioke was one of them, about 5 of them involved in total in 2 different sessions, you know, and saying this is what a clinic consultation about PrEP and HIV look like today. What's your opinion on this? And from there, we drafted the script. So the script was kind of a blend between what already happens and what we hope is going to happen going forward. And then just looking at, oh, these are the areas that we actually already do, you know, what is in the script, and these are the areas for improvement. And then from there, I don't know if some of us who might have seen the PrEP.Scott video for Black African communities. The actor on that video is also the same actor who was on the HIV testing video. And one of the reasons why we did that was we worked with professional actors, but wanted people who had previous experience of, you know, sexual health and HIV. Because I guess having the capacity to exude the emotion for the video is part of the entire process. So we used the casting agency for that, to get actors who were already invested in the kind of work we're trying to achieve, but have the experience as well. And then we filmed them using, you know, pulling on different resources, filming in GCU, which was an amazing help, you know. But I think one of the things that's most important about the entire process is everyone was involved and carried along up until the point when even the community members, you know, there was no going forward without their approval on, oh, this is the first edit of the video, as well as, you know, the clinical input. This is the first edit of the video. What's your thoughts? What do you know, think should happen next before we came out with the finished results?
Great, so lots of learning. And Chioke, from your perspective, what did you learn from being involved in this? What were the main learning points for you?
Hi.
Hi.
Okay. I think for me it is the opportunity I had to interact with people on topics surrounding HIV PrEP. Yeah, it was a learning process for me. I mean, before now, I didn't think it was something I could do, discussing this, because I think at some point it got to talking about some sensitive issues like sexuality, and yeah. So it was, I mean, it was a process of a time of interaction for me with other community members. Yeah.
So a good chance to speak to other people in the community about PrEP and sexual health.
Exactly.
Great. And just maybe moving on to you, Lindsay, as the clinician who was involved in the, you know, actually being in the videos, what was the main learning point for you?
Thanks. Yeah. I think there was a couple of like big ones, really. Probably the first one being just the sort of subtle things that we can do that are actually quite powerful for people when they're coming into clinic, you know, like asking them how they'd like to be called, like their title or pronouns and things like that. Just even like thanking them for their time and explaining like why you've asked those questions or what the follow-up plan is going to be, and just making it so that they know that they're very much part of the consultation. It's very bi-directional, and I think that helps to build like a very respectful doctor-patient relationship. I feel like I'm probably going to steal some people's thunder by saying this, because Claudia's already alluded to it, and it definitely wasn't my input necessarily, but some of the phrasing is extremely important. And I had absolutely no idea some of the stuff that I'd been saying for years and how that can be misinterpreted. Essie's putting up his hand, I've stolen his thunder. But a big one, I think hopefully people noticed, was that when we talk about partners coming in for testing, I always would just say, oh, your partner also needs to come in and get tested or treated. And I didn't realize that was putting like a sort of, like a directional sort of, you might have passed that infection on or something. So actually people found it much better to discuss both people having an infection and both people being treated as like a much more appropriate and acceptable way to phrase that. So that was one of my biggest learning points. Sorry, Essie.
That came across really strongly in the videos. So I'll maybe go to Essie, and then Claudia, if you wanted to add anything on that point.
Yeah, no, not at all, Lindsay. No, it was something that popped in my head whilst you were speaking, because like I said, it's like there was learnings from the videos themselves, but the workshops with community members, like over like three sessions with some community members on a different angle, and then 2 sessions with community. There was so much that came out of the discussions that, you know, it was, as you know, simple things like, oh, this is the way we phrased it, and this is the way we didn't phrase it, or this is how we said this. But it's like when we looked at the principles behind them, there was the principle of trust and power balance. So if I don't feel like I have a say in my consultation, all of a sudden I see the clinician as this high and mighty person. But if they give me the chance to express myself, how do I want to be addressed? Thank me for my time, you know, give me the space to ask questions, but also notice when I'm uncomfortable and dial down. It's like all of a sudden, I feel like I'm in control of the situation as well, but also looking at things like making sure there's no knowledge mismatch. You know, what an example of like, what are STIs, you know, that can be an easy just gloss over. Oh, you could be at risk of STIs, but it's like, is the person in the room actually aware of what STIs mean? Or do they understand what chlamydia actually is? You know, it's not a situation of take your treatment and go. This is what chlamydia is. You might not need the information, but you know it in case of next time when you come across it, those kinds of things. And I think the last strong one, which I don't think I can ever forget, is the community members said, like, very, very explicitly, no one in any way or form wants to be denied information. Everyone wants to know what they want to know that will be useful for them. It might not go the way you expect. You know, we might make mistakes. We might offend someone. That is just life. But we would not use that as an excuse to not give the right information. So we should focus less of our energy on the anxiety of, oh, I might cause, you know, problems or anything. I'm focused more on, if I do mistake or make a mistake, based on these other building blocks, I can then work with who is in front of me to address this so I don't make the mistake next time, but also they've not left feeling like they've got only half-baked goods.
Thanks, Izzy. I think I'm almost out of time. Is that right? Maybe just to you, Claudia, for one final question. What are our kind of future plans? You know, what will we do next? Any thoughts?
I think looking at different scenarios, again, co-produced. So a question of clinicians, whether they're doctors, nurses, pharmacists, GPs, saying, okay, where do I find it? And I think of particular scenarios that I find it really difficult to start the conversation, working with our co-production team so that we can just have more, because I think really it is precise moments. It's absolute pivotal moments in conversations. And that relates to what everyone has said to date. And we feel if we get them wrong, we've just stuffed up that relationship. We might have made somebody feel deeply unhappy. They don't trust us, they don't trust the service, and we can't go further. And so coming together to actually think, okay, we've got a few more on our list that we would really like to do, but always welcome suggestions from others about particular elements in conversations, because what's different here, I think, is because we've focused it on the clinical consultation, because there are lots of lovely resources, as we know, that look at raising awareness. But this for us was, you know, selfishly from our clinical perspective, please help us in our workplace to have these conversations. And just the final point, there are many of us who are very experienced HIV clinicians, and many of us who have had experience perhaps outside of Scotland with many people from different communities. We have hopefully honed our cultural competence over years of looking after people who have a diagnosis that they know about. So the elephant is very much in the room, but the elephant is being talked about. Whereas in prevention, the elephant in the room might be this, how do I raise the issue? Whereas for those who've looked after people living with HIV, the issue is on the table and we're looking at clinical management. And the cultural competence, certainly, that I hope I developed looking after people living with HIV from communities of colour, wasn't that much help to me when I started talking about PrEP with people from those communities. So I think it's really looking at the subtleties, but crucial differences here too.
Brilliant, thank you. So I'm now going to hand over to Jen, I think, for the last session.
Yeah, thanks, Grant, and everyone. So this is really just an opportunity for anyone in the audience to ask questions or give comments. So you can do that in the chat box at the side. I know a few people have already been using that, which is brilliant. So far, there's been quite a few comments, just people sort of really liking the videos, some positive feedback, and asking for the videos to be shared, which I know Essie will be doing afterwards. So that's great to have an appetite for the videos. Some suggestions as well, actually, for use of the videos in educational establishments, as well as within healthcare settings, and within kind of wider community groups. So that's fantastic, a great idea. And some links that have been shared as well to the Positive East videos if anyone wants to see them. There's been a couple of comments asking around videos for nurses, or with nurses in the videos, as nurses obviously do have a key role in delivering PrEP. And I just wondered, perhaps Lindsay or Claudia, if you might want to say something to that.
Yeah, I suppose my question is why, and I don't mean that in any rude sense. We work within sexual health clinics as completely multidisciplinarily. It happened to be Lindsay doing this because I'm Lindsay's educational supervisor, and I thought she'd be brilliant, and she was, and Lindsay happens to be a doctor. I also supervise advanced nurse practitioners and other nurses. So I'm interested in why, but I also want to put forward the view, and I can see that there may be why, so that people don't think it's just a doctor thing, but also to say that within sexual health, certainly within our service, we're pretty much interchangeable in terms of these conversations about PrEP. And I know there's a big thing that if you don't see it, you don't think it applies to you. But I did want to make this really clear that it's coincidence that we happen to both be doctors. The clinician could be a clinician of any ilk. It just happened to be Lindsay, who happens to be a doctor. But I'd be interested to hear, because there may be something that I haven't appreciated as to why it's very important that, you know, Lindsay, if Lindsay had called herself a nurse, she wouldn't have said anything different. But maybe it's important that somebody does call themselves a nurse in order for these resources to be appreciated by the clinicians as available for everybody. So maybe if the person who asked could get that back in the chat, I think I could learn something.
Brilliant, thank you, Claudia. I think it was Karina who doesn't have a microphone or video. So yeah, please do put anything in the chat box there, Karina. So there's a question from Fatima, which has just come in, saying Black Africa is diverse and culture can be complex. How do you adapt your approach to individual patients? And would you approach patients from Somalia and Nigeria, for example, in the same way? So that's a fantastic question. Again, probably more at the clinical level, but Essie, if you've got any inputs, or Chitoki as well, please do come in.
Yeah, I was going to say one of the things when we're filming the videos, and I've not said this enough, and I know Claudia has, but I was amazed at how, you know, how quickly Lindsay was, because she had like a lot of work, but also it's like learning the lines for the script. When I typed up the script, I was like, oh my God, I think Lindsay is going to hate me, but she did everything well. But I think one of the things that came out from after, like our just personal discussion afterwards, was there's things you say in the moment that you don't realize have either caused offense or might make someone feel, you know, different, or make someone feel upset. And it's about retracing your steps from there. And so just addressing the question of, yeah, you know, communities are diverse, and that's exactly what you know, I said at the beginning. So even within Nigeria, I'm from Nigeria, I would not expect to behave and exhibit the same way someone from, you know, I grew up in the West, someone from the South would exhibit or behave. Where the key comes in is reading the room and reading how your interaction has affected the person, because in the end, because of how sort of personal sex and sexual health are, it's almost impossible for you to not see the person's reactions when you say a kind of word, or when you use a kind of sentence, or when you know, do something. As there was the time when Lindsay was, you know, turning to the computer to take notes, and that line came in specifically for, I'm listening to you, so don't imagine I'm just there typing away, being all, you know, high and mighty. But, you know, so it's about reading the room, reading the person, and taking the person-centered approach. I know it's used all the time, but still using the person in the room as your guide to how to approach the conversation with that particular person, and not just, you know, using a one-size-fits-all, because that doesn't work.
Thanks so much, Essie. Lindsay, did you want to come in there?
Yeah, I was just going to add, like, I mean, obviously that's a great point, and yeah, totally like well made. I think, yeah, on the shop floor, like in my day-to-day work, I never want like what I'm doing to seem kind of like tick boxy, like I'm just asking these questions, you know, yeah, because I'm just, the computer's asking them, so I'm asking them. But from like speaking to the community members, like the feedback that we got, even like the actors on the day, a lot of the feedback was that people like to be reassured, you know, actually, these really are routine questions. We ask them of absolutely everybody. And kind of like feeding into that is that when people attend our services, you know, we're asking extremely personal questions. They can be very strange. They might seem really intrusive. And if it's someone's first attendance, they might not actually want to be totally honest. And I think that's completely fair. And we have to be accepting and just acknowledge that. So then when we're giving information, just try and give it to everyone. I think Essie said earlier, like, we want to know, like, people want to know that information. So if we can just give it to everybody, then it takes away that kind of targeted issue, I think.
Thank you. Yeah, it sounds like the videos are great for providing examples, but it shouldn't detract from that kind of conversation with somebody in front of you, and that you shouldn't be scared to react to how the conversation is going. Fantastic. So let me just have a quick look on the side here. I've actually got a question as well around the co-production process, because I'm quite interested in that, and I think it's fantastic that that's how you've developed the videos. I just wondered, like, what were the key challenges? You've sort of mentioned a couple, but just what was tricky about it, and what would you maybe do differently if you were going to do it again? I think Claudia's going to come in there.
I was actually going to say Essie might want to start, because Essie has seen both sides of this. And what I mean by that is that in my happy world, I like everyone to get together. So I was expecting to have sessions face-to-face with some of the community group members and Essie, and I was a bit fretting as to logistically how we might do it or where we might do it, because I thought in my happy land that that was the best way of doing it. And I had to learn really quickly that the community members under Essie's guidance thought another way of doing it would be better. So I was absolutely happy to follow their example, but intuitively it wasn't my first go-to approach. So maybe can I hand over to Essie, who was involved very much with the community group member sessions and with Lindsay and me, and bridging between those two at every stage of the process.
Absolutely. Yeah, it was an interesting dynamic at the beginning to not have everyone all in the room at the same time. But the main premise behind that was, first of all, leading back to the balance of power. I just, from the experience I've had with working with minority ethnic backgrounds, but just, you know, communities who have ever, you know, been excluded or felt excluded from services, is the first time around, putting everyone in the same room might not be the best idea. Bridging the gap by having something like, because this is the first time we've done this, but this is the first building block, because the next time people coming together will be coming together on a foundation of these videos. And it's one of the things, you know, in terms of what does the future hold? This is kind of a building, this is the foundation for, now we can start looking at the process, because we have seen, you know, I'm very sure, you know, the clinical input, Lindsay and Claudia, I've seen the commitment of the community members into this process, but the community members have also seen the involvement from the clinical side. And it's like, oh, we're all in this together. So when we sit down together next time, it's going to be a conversation rather than a feeling of, maybe I should just keep quiet because I've not had prehistoric good experiences, you know, for different reasons or things like that. For co-production, it takes time. It does take time, and I think that's one of the things we're learning, and we need to keep learning, is if we put time on, because we're trying to reach a lot of people who, you know, different tons of phrase, but hard to reach, which I don't subscribe to, and I believe most people in this room don't. But it's like we're trying to reach it's like we're trying to cross over the last step to make sure we engage everyone that we've missed before. And that is not going to take the same time as everyone who walked into our doors or who the doors were wide open enough for them to walk into. So it does take time and it takes resources. And I think that's the key thing that we've learned from co-production, is that it should not be the last strand of the thought process. It should be the first thing, because then if it is, then it means we can allocate, you know, enough time and resources to it, but also just celebrating the work of everyone who was involved, you know, even to the actors, you know, because yeah, they're actors, but they also had personal like interest in doing this, and they also kind of saw the videos before they went to the rest of the public, because it's the kind of process of, we want everyone to feel like they're welcome and they're involved and they're part of the entire process. It's not just someone did this and then they've taken it forward by themselves.
Yeah, I think it's an excellent example of true co-production at the heart of a project, and you can really see that in the outputs. And there's a couple of comments just congratulating you again, in particular on the co-production, which is lovely. And Shona Gibson's written actually that she'd like for you to come and do, I think CME, I'm not sure what that means, but training, I guess, for the whole team from admin to clinical lead. And just on that point, I just wondered if there is a kind of formal plan to roll this out for training, or to incorporate it into training. Have you thought that far? I know you mentioned Public Health Scotland and some other organisations, but just any more information on the kind of clinical and community rollout, I guess, for these resources?
I think if I make a start with that, a lot of our wider friends and family, metaphorically, are on the call. We have, Scotland has always been extremely well placed in terms of linking with the other countries in the Union. And I'm delighted to see some of those people looking at a PrEP rollout in England on the call today. We like to do things together. We like to share resources. The life's too short for reinventing wheels. So anybody can use these resources. We will try and publicise them as much as possible, certainly within the, for the healthcare professionals, within the professional organisations, that's British Association for Sexual Health and HIV, British HIV Association, Public Health Scotland are happy to publicise them, as we mentioned, within the clinics, and within local rollout, we will certainly do that. Any advice or any other ideas that people have for that context, please do just pop them in the chat, because we're using our links, but I'm sure there'll be many more. I know that people have put fantastic ideas about who might want to use them outside of the clinical context. And I think, Essay, I'll hand over to you now to think about use of these more broadly than the clinical context, clinician training and healthcare professional awareness.
Just to say on that note, like, I think this has given a template for replicating this process in different situations. So we are definitely going to be working on more, and there's going to be a survey at the end of the event looking at what you think as well as areas to focus on, whether within a clinical setting or within the community setting, because this is like a sneak peek, but there's one video yet to come out which looks at a community-led approach to sexual health and HIV, and it's the premise of that is the community is the first level of support, spoken by the community members in their own words. The community is the first level of support, and the clinics should be the backup going forward. And so the video is taking the sort of responsibility out from within the community, the clinic into the community. So yeah, that's going to be this is an exciting model to sort of use going forward.
Brilliant. Thanks, Essie. And Grant, I know you've got your hand up, just to say we've got a couple of minutes left. So as soon as you've done your comment,
yeah.
Please can you just pass over to Essie to finish up?
I will do it very quickly. Yeah, it was just really echoing what Essie was saying, that we're really keen to do a lot more of this, and I think the model's fantastic, and I think, as Essie said, it's a good blueprint really for other videos. We're determined that everybody has access to, well, equal access to sexual health testing, PrEP, etc. So we want to do far more of these. So I hope it is just a start. Yeah, and I'll hand over to Essie.
Thank you very much, Grant. Just to say thank you to everyone who's showed up today, taking an hour out of your busy schedules. Really appreciate coming out or coming online to watch these videos and to have these discussions with us. after the event, I'll be sending out an email to everyone just to give you the link to Waverly Care's website, where the sort of video resources and this recording as well will be hosted. So you'll be able to watch that alongside and share them with anyone who might benefit from watching them. The most important thing I just want to say now is thank you to Chijioke as well. And I know there's some of the involved community members in the audience. The blood, sweat, and tears that was put into the process, but also the enthusiasm for the next step, because I think they're the ones who are pushing me forward. It's like, when is the next thing happening? And when are we going to be working on the next thing? And so there's going to be a peer education model coming out of this process, and there'll be more videos to go alongside with the peer education model. But the idea is, again, for the community to be the first seat of support, and for the clinic to be the secondary place for people to go with the more technical stuff, or with the healthcare side, in terms of managing the clinical side. I hope you have a wonderful rest of your day. Thank you to everyone who was on the panel. Thank you to the chairs, Jen and Grant. Thank you, Lindsay and Claudia, for squeezing me in on short notice. Every time just been like, oh, I need to have a chat because this is the feedback I've just got, and we need to discuss it and see what the next step is. Have a wonderful rest of your day, and hopefully see you all in another avenue soon.